So again, thanks very much for asking me to speak today. So my brief today was to talk about common toxicities of new anti-cancer therapies and their management. And I guess I've been working in oncology for about 25 years now. And when I started in oncology, we had a handful of chemotherapy drugs, and radiotherapy was given, and that was the treatment for most cancer patients. It's such a different world now, 25 years later, in terms of how we manage cancer patients in terms of their treatment. There's been so many new therapies developed over the years, and if I was to go through all the new ones, I would be talking to you for days. So I've just picked out a few key ones, and I'm just going to talk. So the ones I'm really going to talk about today are the Cdk4 inhibitors. So I know you had a very good talk from Professor Walsh earlier, and she mentioned these drugs. I'm going to look at epidermal growth factor receptor inhibitors, drugs that we use for lung cancer. Likewise, the anaplastic lymphoma kinase inhibitors, again, drugs we use in lung cancer. And then talk about immunotherapy, because really immunotherapy is the buzzword really in oncology treatment at the moment. I'm sure you've all know a little bit about it, but just to give you an update on it. So the first drug that I want to talk about, as I say, is the Cdk46 inhibitors. And I know Professor Walsh has already discussed this with you already today in terms of mechanism of action, so I don't need to go into any much detail. But as you know, Cdk is an enzyme important for cell division, getting the cell from the G phase to the S phase. And estrogen receptor positive patients seem to depend more on this enzyme for their proliferation. So we use these drugs. What we want to do is block that proliferation, obviously, of cancer cells. So we use it in combination with anti-cancer therapies to help, reduce or delay progression of disease. So what drugs are we talking about? So there's three main drugs that we use as the Cdk4 inhibitors: ribociclib, palbociclib, and abemaciclib. At the moment, ribociclib and palbociclib are the two drugs we use because they're the ones that are reimbursed. We are waiting for reimbursement of abemaciclib, which is due soon. So what are the potential side effects or adverse events with these drugs? So by far the most common side effect we see, particularly with the palbociclib and ribociclib, is neutropenia. We also note hepatic impairment, which would translate as elevated transaminase, the AST, ALT raised. Patients can develop mucositis, diarrhea, nausea, vomiting, interference with their taste, rash less commonly, fatigue, alopecia. Patients would note they don't usually have complete alopecia, it's more hair thinning. And we do note QT prolongation, particularly with the drug ribociclib. So I'm just going to focus a little bit on neutropenia because that is, as I said, by far the most common side effect we see with these drugs. And if you just look here at the Paloma clinical trial program, so that's a combination of different Paloma trials looking at palbociclib. All grade of neutropenia was 81%, but there was, in terms of grade 3 to 4 neutropenia, it was as high as 65%. The important thing, or the key thing, or the interesting thing to note is that actual febrile neutropenia in these studies was really very, very low. So the incidence in the Paloma 2 trial was 1.8%, and the Paloma 3 trial was 1%. So although 65% of patients are developing grade 3, 4 neutropenia in these trials, only, you know, a fraction of that number actually developed a febrile neutropenia. So as you know, febrile neutropenia is when patients develop a temperature, picks up an infection, and it is deemed an oncology emergency. Likewise with ribociclib trials and the Mona Lisa trials, again, all grade of neutropenia was 74%, grade 3 to 4 was 60%, but again, the incidence of febrile neutropenia was 1.5. So how do we manage the neutropenia? So this is, quite a busy slide, but really what I just wanted to point out was when we start patients on these drugs, we review them day 1 and day 15 for the first 2 cycles. So the scheduling of these drugs is they take the drug day 1, day 21, and then they have a 7-day break. But for the first 2 cycles, we do see them day 1 and day 15 just to check their bloods. For patients who develop a grade 2 or less neutropenia, we just continue on the same dose. For grade 3, and a grade 3 neutropenia means their neutrophils are between 0.5 and 0.9. So we would hold treatment at that point until they recover to a grade 2 or less. For grade 4 neutropenia, again, we would hold till it recovers to a grade 2, and then we dose reduce it by 1. So one key thing to note about all these drugs is that they all come in different strengths. Okay, so starting off with, say, for palbociclib, it's 125. If we needed to dose reduce, there's a 100 milligram dose drug. Obviously, if somebody develops a neutropenic sepsis, as in a high temperature infection, we treat it as a febrile neutropenic protocol. It's an oncological emergency. Patients need to come in, get started on IV antibiotics, get septic screens and done. When they recover from that, again, we would dose reduce them. In terms of managing the other side effects, which are, I guess, less common, really supportive care. And what I mean by that, and I'm going to use this, and I know you had a lovely talk earlier about supportive care for patients, it's really about managing the individual side effects. So for example, if somebody is having diarrhea, again, we would grade the diarrhea, and really depending on how bad the side effect is will help us, guide us how we should manage the side effect. So to use antidiarrheal medication, obviously I talk to patients about their diet in terms of having a low roughage diet, drink plenty of fluid. If they're having more than a grade 2, which would be, 4 to 6 episodes of diarrhea or more a day, we would need to see them. We need to make sure that they're, not becoming dehydrated. Again, rare with these drugs. Dose interruption, obviously, if somebody is having any sort of bad side effect or high-grade side effect, we would obviously stop treatment. And again, that I suppose is the beauty of these oral therapies, is that we can just stop it at a moment's notice. And if needs be, we can dose reduce when they do recommence. So I guess in general, these Cdk4 inhibitors are well tolerated. Neutropenia by far is the most common side effect, but we do need to keep out, particularly when abemaciclib does become licensed. If it is used, we need to keep check, because that is a higher incidence of diarrhea. For ribociclib, the QT prolongation is noted. So again, when we start that drug, we do keep an eye. We do a baseline ECG and an ECG for the first few times they come to see us. So next group of drugs that I wanted to talk about today are drugs that we use for non-small cell lung cancer. So there has been such an explosion in terms of treatment for non-small cell lung cancer. And a lot of this is, well, some of it is certainly down to discovering, targetable genetic alterations that are promoting the growth of these cancers. And the two that I want to focus on today are the EGFR positive non-small cell lung cancers, and the ALK positive non-small cell lung cancers. And this is just a quick graph to let you know that within lung cancer, there are many genetic alterations have been discovered. Some are targetable, and as I say, the ones I'm going to focus on are the ALK and the EGFR mutations. But there's a lot of unknown mutations and a lot of other mutations that, again, that are being studied and looking to target. So with regards to the EGFR positive lung cancer, it's found in about 50% of Asian patients and about 8 to 15% of Caucasian patients. The interesting thing with this type of mutation is that it tends to be diagnosed in younger patients and never smokers, and those patients who have an adenocarcinoma histology. So that is the interesting thing for people who have never smoked. They tend to, for some reason, develop this mutation. So in terms of drugs that treat these this mutation, there are a number of different drugs. So about 10 years ago, Tarceva came on stream, and I just remember when it came on stream first, we had to apply to the company, and there was this big long form that we had to fill out, and the consultant had to sign it. But we've come a long way. There's now a number of drugs, and we're up to the 3rd generation of these drugs. So osimertinib is probably the drug, along with afitinib, or they're probably the two drugs, TKIs, that we use most commonly for treatment of this mutation. So this is just a quick graph in terms of when these drugs are used. So I guess the 1st generation was the erlotinib, gefitinib, going up to the 2nd and 3rd generation. And I suppose the difference between these drugs is just the activity range. So as you go up along the line, the newer generations tend to be more potent. When osimertinib was first developed, it was specifically for this mutation, the T790 mutation. And when it was first licensed, it was only for patients who had that type of EGFR mutation. But now it has actually been licensed for any type of EGFR mutation. So it is probably the go-to drug first line. So what are the potential side effects with these drugs? So I suppose the key side effects that we see are diarrhea and rash. So they would be certainly the two more common side effects that we see with these drugs. Stomatitis, paranoia, which is lifting of your cuticle. You know, patients get fatigued. I suppose the rarer, but I suppose more life-threatening side effects, interstitial lung disease and cardiac effects, again, the QT interval prolongation are noted, and neutropenia, again, would be very much less common. So this, I just put this picture up to show you the type of rash the patients can develop. So you can see there, it's like a macular papular rash, and it can be nasty, and it tends to affect their chest and face. So, you know, it can be very distressing. Again, I just remember when we started using these drugs, and patients used to come in with just awful rash on their face, very uncomfortable and very visible as well. So how do we manage these? So again, my slide in terms of management, again, supportive care, dose interruption, and dose reduction. So we just go back to look at the list of side effects. So with regards to diarrhea, again, we would have a low threshold. We would usually give a patient a prescription for Imodium when we start these drugs, and say, look, if you start having diarrhea, start taking the Imodium. Obviously, they need to link in with us, because we don't want them at home having, you know, a grade 3 or 4 diarrhea and becoming dehydrated and that. With regards to the rash, again, we would have very low threshold starting minocycline antibiotic. And obviously care in terms of using creams, you know, avoiding direct sunlight, using an SPF would be important. You know, when they're drying their skin, not to rub it too hard, you know, to pat it dry. Just one thing I learned actually last week from one of our dermatology regs in terms of when we recommend patients to use, you know, good moisturizers, you know, we often would recommend emollient creams. The one thing about emollient cream is that it has got liquid paraffin in it, and she was saying they often don't recommend it for people who smoke because the liquid paraffin can rub off on the clothes and they can be a little bit more inflammable. So that's actually, I had never thought of that. So if they're non-smokers, as a lot of these patients will be, liquid or, you know, the emollients are okay to use. If there's any doubt, something like Silcox base or that. So I suppose the key thing with all these side effects is really getting patients from day one to practice good skin care, rather than trying to, you know, so sort of prevention can certainly help reduce or minimize these side effects. In terms of interstitial lung disease, again, it can be difficult because obviously these patients have lung cancer and they may have, you know, underlying poor lung function. And again, because of the cardiac effects, we do, when we start many of these drugs, we would do a baseline ECG, and for the first few visits, do a check ECG just to make sure there isn't any issue with TQ prolongation. So then with the ALK positive lung cancers, so again, deregulation of the ALK kinase or the ALK leads to uncontrolled proliferation of cancer cells. Again, the portion of patients is much smaller as opposed to the EGFRs. It's only about 3 to 7%. But again, it's very important for a patient to know because it is very actionable or very treatable with these drugs. Again, patients tend to be younger at diagnosis, never smokers, and have an adenocarcinoma histology. So in terms of drugs, again, there's different generations. So we're up to the 3rd generation. Lorlatinib and crizotinib, very commonly used. And again, like the EGFRs, the higher the generation, the more potent the drug appears to be. And with the ALK, they would note that brain penetration tends to be more evident. So again, just a little schemata showing that all these drugs, as they're oral, they work intracellularly, and just to stop the down signaling pathway and try to reduce cell proliferation. So again, in terms of side effects with these drugs, again, gastrointestinal effects, nausea, diarrhea, vomiting, constipation, fatigue. We do see a bit of edema or fluid retention with these drugs, and some patients can develop peripheral neuropathy. We do see hyperlipidemia, again, particularly with lorlatinib treatment, altered taste, visual disturbance with crizotinib, again, elevated transaminase and cardiac and interstitial lungs. So again, some of these are quite similar to the EGFR side effects. And again, how do we look at supportive care, look at dose? Again, as I said earlier, all these drugs have different dose or different drugs or dosing of drugs, so it's easy to dose reduce. So that is always an option if patients are struggling with AEs. One key thing that I wanted to mention today with regards these oral drugs is really drug-drug interaction. So this is just one of the take-home messages I wanted to emphasize today. And this, you know, drug-drug interaction can occur at any step in which the drug interacts with the body, being it during absorption, distribution, metabolism, or excretion. And many agents, for example, food, drug transport transporter inhibitors or inducers, for example, the P-glycoprotein or CYP inhibitor induces can lead to drug-drug interactions. And what does all that really mean? So basically it means if you have a drug-drug interaction, it may increase the level of the TKI in the plasma or reduce the level of the TKI in the plasma. Obviously, if you have an increased level of the TKI in the plasma, you potentially will have more side effects. So a lot of the EGFR and ALK TKIs are metabolized within the CYP pathway in the liver and the intestine. So just as I said there, potent CYP inhibitors can increase the plasma level of certain EGFR and ALK TKIs, and certain CYP inducers can reduce the plasma level, and likewise with the glycoproteins as well. So this is just an example in terms of the EGFR drugs of what drugs may interact with them. And just the key ones that I wanted to point out today, because, you know, there's always long lists of drugs that we never use routinely, but the ones that we may use routinely for our patients are the gastric acid reducing agents, so the protein pump inhibitors, or the H2 receptor antagonists, or any antacids. So particularly with erlotinib and gefitinib, and they can decrease the exposure of the TKI in the plasma. Inducers, again, St. John's wort appears on every list. I don't know anyone who's ever used it, but anyway, it's always there. And some here in the inhibitors, you've got numerous, you know, antifungal, anticonvulsants, and some antibiotics like ciprofloxacin, you know, is used quite commonly. So it's just to be aware. I mean, I can't give you a whole load of lists, you wouldn't remember it anyway, but it's just to be aware that if you're starting a patient on a drug, be it an antibiotic, be it, you know, particularly antiemetics as well, just to note that there could be a drug-drug interaction. Again, with the glycoprotein inducers and inhibitors, again, there's a number of antivirals, antibiotics, and also grapefruit juice. I think it was on the previous one. Grapefruit juice is another no-no that patients should avoid. Likewise, with the ALK inhibitors, they talk about grapefruit juice, they talk about St. John's wort, again, the gastric reducing agents, because the gastric reducing agents may actually alter the solubility of certain TKIs, thus reducing its bioavailability. So that's really the key. The other thing to note that we have to be careful in terms of concomitant use of drugs that may prolong the QT interval. So as you see here, a number of antiemetics do in terms of ondansetron and Imodium that we would use, and, you know, some of the antifungals as well. So these are drugs that may prolong QT intervals, and if we're giving them with other drugs that can prolong QT intervals, well, then you're more likely to have a problem with that. So really the take-home message in terms of drug-drug interaction is just that if you're starting a patient on a drug for any other side effect that they may be having for supportive care, that you just need to doubly check in terms of drug interaction. Maybe let us know, maybe we can you know, change the drug, or, you know, certain drugs may not have the same high drug interaction as others. So some can be a higher inducer, some can be a moderate inducer of these drugs. So the last part of my talk today, I wanted to focus on immunotherapy. Now, I know you've probably had lots of talks about immunotherapy, but I think it is a key topic because it is now just, it's just, there's such waves of immunotherapy use in oncology now, and it's just ongoing every day. There's a new indication for immunotherapy, and It's growing. When it started, it was mainly focused with with melanoma patients. Now we use it for melanoma patients and so many other diseases. So what is immunotherapy? So basically, they're drugs that harness our immune system to recognize and kill cancer cells. And basically what these drugs do is they overstimulate the immune system by taking the brakes off the immune system or by keeping the immune system switched on. So really what we're doing is we're sort of overstimulating the immune system because we want the immune system to recognize and kill cancer cells. So that's in a very layman's term. So what drugs are we talking about? So there's three groups of drugs: the anti-CTLA4 drugs, which there is one of, and that's ipilimumab; the anti-PD-1 drugs, nivolumab and pembrolizumab; and the anti-PD-1 drugs, atezolizumab and durvalumab. So they're the sort of main drugs that we are using in practice. So this is just a really quick line. And again, as I said, you know, the use of immunotherapy is just increasing all the time. So ipilimumab was the first drug reimbursed here in Ireland in May 12 for first-line metastatic melanoma. Then we had pembrolizumab, and then with the combination in October 17. And then we got a license. This is all in Ireland now, just what is reimbursed, because it is strictly controlled. So then we got it for renal cell, for Hodgkin's disease, and then it went into for lung cancer, so non-small cell lung cancers who don't have an EGFR ALK mutation. Again, for head and neck cancers. And then newer drugs were coming on streams for lung cancers. And now recently, the most recent approvals just this year, we've got ipi-nivo for first-line metastatic renal cell. We now have got approval for nivolumab for adjuvant melanoma as in stage 3. We're now combining immunotherapy with chemotherapy. So that is for first-line lung cancer. So that's been reimbursed just there in February. And again, durvalumab for locally advanced unresectable non-small lung cancer after chemo RT. So as you can see, and here in Vincent's, we use it also for second-line for cervical cancer patients. So as you can see, the reason why we're using these drugs, the number of diseases is definitely increasing. So with regards to side effects of these drugs, basically immunotherapy can cause or can affect any organ of the body, okay? So it can just cause basically inflammation of any organ of the body. The common ones we see are skin, so it can lead to a skin rash. Again, it can be a macular-papular type rash. Severely, which we don't thankfully see very often, is Stevens-Johnson syndrome. It's very rare, but it does happen, so we have to be alert to it. It can cause gastrointestinal adverse events, for example, diarrhea, colitis, autoimmune hepatitis. It can affect the endocrinopathy. You can get on endocrinopathies, including hypophysitis, thyroid issues, hypo or hyperthyroidism, or adrenal insufficiency. You can also have issues with the lungs, inflammation of the lungs leading to pneumonitis, and nephritis. So they're probably the more common side effects we see. Rarer ones then would be the myocarditis, the arthritic type side effects. So what are the incidents of these side effects? So this is quite a busy slide, but I just wanted to point out, it's a slide from one of the clinical trials, the Checkmate 067. And this trial looked at the combination of ipi-nivo versus nivo versus ipi. And really what I wanted to point out is that firstly, these are the list of adverse events, and skin rash in this trial was definitely the more common side effects. So skin rash, gastrointestinal side effects, hepatitis, endocrine, and pulmonary. If you just look at the incidence, so this is the combination of ipi-nivo, and within this trial, in terms of skin rash, 5.8% of patients had a grade 3 to 4 skin rash. As opposed to people on single agent Nivo, it was 1.6, and with IPI, it was 2.9. In terms of diarrhea, so again, having a grade 3 to 4 diarrhea, around 9% of patients had a grade 3 to 4 diarrhea with the combination. With single agent Nivo, it was 2.2, and with single agent IPI, it was around 6%. So really what I wanted to highlight here was that when patients are getting a combination of IPI-Nivo, certainly the side effect profile can be worse, and we definitely see more grade 3 to 4 side effects than if you use it single agent. We tend not to use single agent IPI very much anymore. So the only two diseases now that we use combination IPI-Nivo for are melanoma and for renal cell cancer. So as I say, when you get a combination, if a patient is on a combination of these drugs, definitely the side effect profile can be higher. So how do we manage them? So the general management, I suppose, just really depends on the immune-related side effect that they have. And it also depends on the severity or the grading. So we very much use grading in terms of managing or deciding how we will manage the side effect. So we have to continuously monitor patients. Just one note to highlight here, that it is important when somebody does develop a side effect from immunotherapy that we rule out other causes. So if somebody is having diarrhea, for sure, and they're on immunotherapy, it is likely related to the immunotherapy, but we just can't, we got to make sure that there isn't, you know, a progression of disease causing diarrhea, or could it be an infection or something related to that. So to outroot infectious or disease-related etiology, again, for something like hepatitis, if somebody has increased LFTs, well, is it due to their immunotherapy? Is it due to their disease? Is it due to infection? So how do we manage them? So looking just at the sort of more common side effects for grade 1, we generally can continue treatment and use supportive care or medicine. So again, if somebody had a grade 1 rash, which technically is 10% or less of their body surface area covered with rash. So often what we would do in that, again, we'd recommend good moisturizing with the emollients or something like Silcox base. If they needed a steroid topical cream, we give them a steroid topical cream, and obviously, you know, keep an eye on how they are responding. If they were having, you know, mild diarrhea, again, we may just use something like Imodium, but we do follow them up closely just to make sure that their grading isn't, their reactions or side effects aren't getting worse. In terms of grade 2 or 3 reactions, again, for these, a lot of side effects, we would often hold treatment and start them on steroids. So usually we try to give the lowest dose of steroids as we can, and we will only give it when we need it, because the one thing about steroids is the steroids counteract what the immunotherapy drugs are doing. So the immunotherapy drugs are stimulating your immune system. What steroids do will dampen it down. So obviously if somebody is having, you know, bad side effects from immunotherapy, we absolutely give steroids. And that is the sort of key for most of these side effects, grade 3, 4, some grade 2 side effects, we give steroids. So as I say, we start off with as low a dose as we can, maybe 0.5 milligrams per kilogram up to 1 milligram per kilogram. Again, if they're not responding to that, we may increase it to 1 to 2 milligrams per kilogram or commence methylprednisolone IV. So again, using IV methylprednisolone will be certainly for things, for patients who are having maybe grade 3, 4 diarrhea, for pneumonitis, so for the higher grade side effects. Other immunosuppressants can be used if the steroids aren't getting the side effects under control. So for example, if somebody has diarrhea, they're on methylprednisolone, aren't, you know, responding within, you know, a day or two, we would potentially look at using infliximab, which is, you know, is an immunosuppressant. So again, the key thing for the other key thing to mention about the side effects of immunotherapy is that they don't always happen even when a patient is on treatment. They can happen with up to 6 months after they finish treatment. So we could have a lot of patients that they may progress on immunotherapy, we may stop treatment, we may, you know, they may be taken over by the palliative care team, and, you know, 2 months later, they could start getting really bad diarrhea. And it could be related to, so it's just something to keep in mind that it could be related to previous immunotherapy. The one, I suppose, side effects that are treated slightly different are the endocrinopathies. So we don't always use, in fact, we don't often use at all steroids unless they were having adrenal insufficiency. But really for the endocrinopathies, I suppose the key thing we do is we replace the hormone that is lacking. So for example, if somebody has had hypothyroidism, we'll start them on naltrexone, and we can usually continue on with the immunotherapy drug. You know, if somebody develops pancreatitis that might interfere with their insulin production, you know, they might need to start on, you know, an oral glycemic or insulin. Yeah, so again, it's really replacing the hormone therapy, and again, with the adrenal insufficiency, obviously the hormone replacement is steroids, so we usually start them on the hydrocortisone. If we do start patients on steroids, the recommendation is that these steroids should be tapered slowly once the side effect has settled. Okay, so again, I'll use the example if somebody has diarrhea. So we start them on steroids, you know, 1 mg per kg, their diarrhea settles. We do have to taper the steroids slowly, because if we taper too quickly, they can get a rebound effect. For patients who will be on steroids, because often patients go on steroids, we start reducing it, the side effect might start to increase again. We put up, so sometimes patients will be bouncing up and down a little bit on steroids. If they're going to be on steroids for any length of period, we do give them Cetrin as a preventative for PCP. So again, just to prevent any opportunistic infections. And then when do we say, look, enough is enough, this patient can tolerate immunotherapy? So this is, you know, the recommendation. If patients have, you know, grade 2, 3 side effect that is persistent despite being on steroids, an inability to reduce steroids to 10 milligrams prednisolone, or for all grade 4s, maybe with the exception of the endocrinopathies, or recurrent grade 3s. So if somebody had a grade 4 pneumonitis, well then we would likely not treat that patient again with immunotherapy. So with regards to the steroids, as I said, we prefer patients not to be on steroids because they can counteract how immunotherapy works. But you know, there is a lot of research into this, and it is now believed that if a patient was on up to 10 milligrams of prednisolone for whatever reason, like we have a patient on at the moment who has autoimmune-related arthritis ever before he was diagnosed with cancer, and he was on steroids for that. So we got him down to 5 milligrams of prednisolone. So we were able to treat him. He's only on 5 milligrams prednisolone. He hasn't had any re-exacerbation of his arthritis. It's certainly not any worse, and he's flying it. So patients can be on up to 10 milligrams of pred safely on immunotherapy if needed. I wanted just to finish with this case study because there's so much talk about immunotherapy. and everybody talks about the expense of it and, you know, all these terrible side effects that can happen in patients. So why do we use it? And we use it particularly because of somebody like Mary, who was 34, diagnosed with stage 4 melanoma to her right breast and adrenal gland. She had 4 cycles of Ipi-Nivo, which she completed in January 19. And she had a PET scan at that point, and it showed a complete metabolic response with no evidence of active disease. She continued on single agent Nivo 4-weekly up for about another a year and a half, up to June 20. And then we stopped her treatment. Now, so I suppose the good side of it is, and I'm just going to show you this, is her PET scan. So this was her pre-treatment PET scan. So as you know, PET scan will light up any areas of metastatic disease, and it's particularly sensitive for melanoma. Obviously, the other areas that light up are your heart, your kidneys, and your brain. But here's her adrenal glands. So that little dot there, that was her adrenal met. And this is a side view of her breast. So you can see there's uptake in her breast. So when she had the Ipi-Nivo, she developed a complete response. So you can see that little dot is gone. So this is her post-treatment. And again, her disease there in her breast is no more. So the fantastic thing for Mary, as we call her, is that she's still in complete remission. So we're still scanning her every 6 months, and she happily is still in complete remission. I am working in oncology long enough to know that very, very, very few patients with melanoma survived, with stage 4 melanoma survived longer than a year. So this is really phenomenal for her. I suppose the downside for her is that she has developed adrenal insufficiency and is currently on hydrocortisone. And we do know with the endocrinopathies, they tend to be lifelong side effects. So it's likely that she will have, beyond, you know, hydrocortisone, adrenal insufficiency will likely be a lifelong issue for her. And she's all recently sort of developed a little bit of inflammatory arthritis as well, which again is interfering a bit with her quality of life in terms of her mobility and just getting around and doing things that she normally would like to do. So there's a lot of good news for her in that she's alive, but you know, patients, I guess, potentially will pay a bit of a cost for it. One resource information I wanted to highlight today, because there are a lot of new drugs and it's hard to keep up and it's hard to keep, you know, an eye on all the new drugs, but the NCC protocols, anytime they reimburse a new drug, they put a protocol up, and it's there on the website. So if you just even look up NCC protocols, sometimes they're called NCCP chemo protocols, but all the newer drugs, all the, you know, EGFR, the ALK, all the immunotherapy drugs, they go through each drug in detail, you know, giving the indication, the inclusion-exclusion criteria for using that drug, and a list of profiles. So I think this is really very helpful. So if you're just ever unsure about a drug that a patient is on, you know, do check it out in the NCC protocols. So that is it. Thank you very much for listening. I hope that you've gained some little bit of extra information about newer drugs, and I'm certainly happy to take any questions that you may have.